Welcome to The Explainer. In this masterclass, we are going to build a really deep, integrated understanding of cardiovascular pharmacology. We're going to trace the entire pathological journey, starting with hypertension, moving through ischemic heart disease, and going all the way to heart failure. And what's crucial is that we won't just learn what drugs to use. We're going to understand precisely how they work by intervening in the body's own physiological pathways.
So what's the connection? That is the central question we're going to answer today. And the connection is something called a pathophysiological cascade. You can think of it like a domino effect. It's where untreated high blood pressure starts to damage the arteries, which can then lead to ischemic heart disease. That, in turn, can weaken the heart muscle, and it all culminates in heart failure. In this explainer, we're going to map out this entire cascade and see how modern pharmacology gives us a whole toolkit to intervene at each and every critical stage.
All right, here's our roadmap for today's session. We'll kick things off with hypertension, which we call the silent problem. Then we'll dive into the pharmacology of controlling high blood pressure. From there, we'll move on to ischemic heart disease, first explaining its causes and then getting into how we manage it. And finally, we'll examine heart failure, really digging into its vicious cycle and the drugs we use to support a failing heart. As you're about to see, each topic builds directly on the last one.
Okay, first up, hypertension, or what most of us just call high blood pressure. It's an incredibly common chronic cardiovascular condition. But here's the thing, it's often asymptomatic, which means you don't feel any symptoms at all. And that silence, that's exactly what makes it so dangerous, because it's a major risk factor for a whole host of other really serious diseases.
So we classify hypertension into two main types. As you can see on the left, the vast majority of cases, we're talking 90 to 95%, is primary or essential hypertension. For this type, the specific cause is unknown. It's understood to be multifactorial, basically a mix of your genetics, your lifestyle, and your age. Then on the right, we have secondary hypertension. Now, in these cases, the high blood pressure is actually caused by an identifiable underlying condition, something like chronic kidney disease or maybe an endocrine disorder.
Now, what's really powerful about this slide is that it shows you exactly why this silent condition is so dangerous. Persistent high blood pressure isn't just a number on a cuff. It's a constant force that physically damages blood vessels all over your body. This can lead to strokes in the brain, retinopathy in the eyes, heart attacks and heart failure in the heart, and chronic renal failure in the kidneys. The complications are widespread and they are severe.
To understand how we treat high blood pressure, we first have to understand how the body controls it. And this flowchart illustrates the two key pathways that get activated whenever your blood pressure drops. Up top, we have the super fast-acting response from the sympathetic nervous system, and on the bottom, we have the slower hormonal response, the renin-angiotensin-aldosterone system, or ROS for short.
Okay, let's break these two systems down in detail. First up, the sympathetic nervous system, or SNS, provides a really rapid response. It stimulates what are called beta-1 adrenergic receptors on the heart. This does two things. It increases your heart rate, an effect we call positive chronotropy, and it increases the force of contraction, which is known as positive inotropy. At the same time, the SNS activates alpha-1 receptors on your vascular smooth muscle, causing vasoconstriction. This squeezes the blood vessels, increasing peripheral resistance and venous return. It also stimulates the kidneys to release renin via those beta-1 receptors, which then kicks off our second system, the renin-angiotensin-aldosterone system, or RAS. This is a slower hormonal response. That renin that was just released converts a liver protein called angiotensinogen into angiotensin-1. Then an enzyme called angiotensin-converting enzyme, or ACE, converts angiotensin-1 into the superactive angiotensin-2. Now, angiotensin-2 is a very potent vasoconstrictor, and it also tells the adrenal gland to release aldosterone. Aldosterone then acts on the kidneys to make them retain sodium and water, which increases your blood volume. So together, the SNS and RAS work to bring that blood pressure right back up.
All right, so now that we have this detailed understanding of the SNS and ROS pathways, you can see the logic behind our treatment strategies. Pretty much every major class of antihypertensive drug works by targeting a specific step in one of these two systems. So let's explore the main pharmacological ways we have to control high blood pressure.
The pharmacological management of hypertension can be neatly remembered with this ABCD mnemonic. The A stands for ACE inhibitors and angiotensin II receptor blockers, or ARBs. B is for beta blockers. C is for calcium channel blockers, and D is for diuretics. Each of these different classes is designed to achieve one of four main goals: to modulate vascular tone, to downregulate sympathetic tone, to reduce intravascular volume or to inhibit those key neurohormonal regulators.
This slide shows us precisely how we can target that RAS pathway. We can inhibit the enzyme renin right at the start with drugs like aliskiren. More commonly, though, we use ACE inhibitors, like ramipril, to block the angiotensin-converting enzyme, which stops angiotensin II from ever being formed. Or we can let angiotensin II get made, but then block its effects at the AT1 receptor using angiotensin receptor blockers, or ARBs, like losartan.
Now, to modulate that sympathetic tone, we use beta blockers. And as you can see here, they have this awesome dual effect. They block beta-1 receptors on the heart, which decreases the heart rate and the force of contraction, and that lowers cardiac output. But crucially, they also block beta-1 receptors on the kidney, which reduces the release of renin. This dampens the entire RAS pathway, so you're tackling both of the body's major pressure control systems at the same time.
Next up are calcium channel blockers, which modulate vascular tone. As this chart clearly shows, they are not all the same. The dihydropyridine class, represented here by nifedipine, causes strong coronary dilation, but also comes with the highest frequency of adverse effects, at 18%. In contrast, the non-dihydropyridines have effects on both the blood vessels and the heart itself. Verapamil shows moderate dilation and a 9% rate of adverse effects, while diltiazem has the weakest dilatory effect, but also the lowest rate of adverse effects, at just 2%.
And finally, we have diuretics, which reduce the intravascular volume. As these steps show, they start by increasing the kidney's excretion of sodium and water. This initially reduces blood volume and cardiac output, but their sustained, long-term benefit actually comes from a secondary decrease in peripheral resistance. It's also important to know the main classes. Thiazides are the most common, loop diuretics are more potent, and potassium-sparing diuretics are often used as add-on therapies. And of course, no discussion about pharmacology would be complete without talking about side effects. This table is an absolutely critical summary for clinical practice. It outlines the key adverse effects for each drug class that a prescriber has to think about. Everything from that persistent dry cough that's associated with ACE inhibitors to the ankle edema that can be caused by certain calcium channel blockers.
All right, now we move on to a direct consequence of risk factors like hypertension, ischemic heart disease, or IHD. That term, ischemic, just means a restriction in blood supply. So, IHD is all about an imbalance between the heart muscle's oxygen supply and its oxygen demand.
The underlying pathological cause of most chronic IHD is atherosclerosis, which is basically a hardening of the arteries. This slide does a great job of visually walking us through its insidious progression. It all starts with endothelial dysfunction. That's damage to the inner lining of the artery. This lets lipids start to accumulate, forming what's called a fatty streak. Over time, this grows into an advanced lesion, and eventually it can become an unstable fibrous plaque, which is very prone to rupturing.
Ischemic heart disease shows up in two main ways. On the left, we have chronic coronary artery disease. This is characterized by that gradual plaque development, which leads to a fixed blockage. This typically causes a predictable chest pain when you exert yourself, known as stable angina. On the right, we have the medical emergency, known as acute coronary syndromes, or ACS. This is caused by the sudden rupture of one of those unstable plaques, which forms a blood clot, or thrombus. Now, depending on how much blockage that clot causes, this can lead to unstable angina, a type of heart attack called an end-STEMI, or a full-thickness heart attack known as a STEMI.
So, as you can probably guess, the treatment goals are dramatically different depending on which type of IHD we're dealing with. For the chronic, stable disease, the primary goal is to rebalance that oxygen supply and demand equation to prevent symptoms. But for acute syndromes, the goal is much, much more urgent. We have to restore blood flow to the heart muscle as quickly as possible.
For managing the chest pain of angina, nitrates are an absolute cornerstone of therapy. They work by releasing nitric oxide, which is a potent vasodilator. And this slide shows their dual action beautifully. They dilate the veins, which reduces the amount of blood returning to the heart. We call this preload. And they also dilate the arteries, which reduces the pressure the heart has to pump against. We call this afterload. So by reducing both preload and afterload, they dramatically decrease the workload, and therefore the oxygen demand of the heart.
Therapy for chronic stable angina is multifaceted, as this table summarizes. We use nitrates like GTN to decrease preload and afterload. We use beta blockers like metoprolol to decrease heart rate and contractility. We use calcium channel blockers like diltiazem to decrease vascular resistance. And critically, we also use other agents to manage the underlying disease itself. A low-dose aspirin to reduce the risk of blood clots, and statins like atorvastatin to lower cholesterol.
Now, in acute coronary syndromes, the strategy becomes way more aggressive. For a partial blockage, like you'd see in unstable angina or an end-STEMI heart attack, the goal is to stabilize the patient and prevent that clot from getting any bigger. This usually involves a cocktail of powerful antiplatelet drugs and anticoagulants. But for a complete blockage, a STEMI heart attack, the saying is, time is muscle. The absolute priority is to open up that blocked artery immediately. This is called reperfusion, and we can do it either mechanically with a stent or pharmacologically with clot-busting drugs.
And that brings us to our final topic, heart failure. This is often the final common pathway, or the endpoint for many unmanaged cardiovascular diseases, including hypertension and ischemic heart disease. It's a pathological state where the heart is simply unable to pump enough blood to meet the body's metabolic needs.
This right here is the absolute core concept you need to grasp about heart failure. A weakened heart leads to decreased cardiac output. In response, the body freaks out and activates its emergency systems, the same ones we saw with hypertension, the sympathetic nervous system and RAS. They cause vasoconstriction and sodium and water retention. Now, this might help maintain blood pressure in the short term, but in the long term, it dramatically increases the workload, the afterload and preload on an already failing heart. This increased work causes even more damage, which further decreases cardiac output, creating this terrible, vicious downward spiral.
So it follows pretty logically that the primary goal of heart failure therapy isn't just to treat the symptoms, but to interrupt this vicious cycle. The entire strategy is built around blocking these harmful long-term compensatory mechanisms that are trying to help but are actually making everything worse.
Modern heart failure treatment hits this vicious cycle from multiple angles. This table shows our primary toolkit. We use ACE inhibitors or ARBs to reduce the effect of angiotensin N2 and prevent harmful cardiac remodeling. We use specific beta blockers to reduce the sympathetic overdrive. We use diuretics to reduce fluid volume and thus preload. And importantly, we use aldosterone antagonists to specifically inhibit aldosterone's harmful long-term effects.
For certain patients in heart failure, we also have newer, novel drugs like ivabradine. This slide shows its really elegant mechanism. It works by selectively inhibiting a very specific channel, the HCN channel, in the heart's natural pacemaker, the sinoatrial node. By blocking the current that goes through this channel, it slows down the rate of spontaneous depolarization. This reduces the heart rate without affecting the force of contraction. This gives the heart more time to fill and also reduces its oxygen demand. In some acute or severe cases of heart failure, we need to directly increase the heart's pumping force. For that, we use drugs called positive inotropes. This diagram shows how many of them work. Drugs like milrinone increase the levels of intracellular CAM. This, in turn, leads to more calcium entering the cell, and more calcium available to the muscle fibers means a stronger force of contraction. Digoxin is another inotrope that works a bit differently. It inhibits the sodium-potassium pump, but the end result is the same. It ultimately increases intracellular calcium.
This diagram brilliantly illustrates that heart failure treatment is staged and progressive. In stage A, for high-risk patients who don't have symptoms yet, we just focus on risk factor reduction. In stage B, where there's structural heart disease but still no symptoms, we add foundational drugs like ACE inhibitors or ARBs and beta blockers in certain patients. By stage C, once symptoms have developed, the therapy expands to include diuretics for fluid overload, aldosterone antagonists, and potentially newer agents like ivabradine or something called an ARNI. An ARNI is an angiotensin receptor neprilysin inhibitor. It's a combination drug that both blocks the RAS system and enhances beneficial native peptides.
So the crucial point of this entire explainer is this. The body's responses to things like low blood pressure or a weak heart are ancient, they're powerful, and they're designed for acute survival. But in a chronic disease state, these same protective mechanisms become destructive. By understanding the intricate details of the SNS and the RAS, we can pharmacologically intervene with incredible precision, not just to manage symptoms, but to fundamentally interrupt the disease process and alter the course of these devastating conditions. We are, in essence, trying to turn a vicious cycle into a virtuous one.